Good morning, everyone. My name is Ariella Herman, and I'm the director of the Healthcare Institute at the Anderson School of Management. I'm also part of the National Center for Early Childhood Health and Wellness, and I'm happy to welcome you to this session and see that there is such an important interest in the subject of health literacy. Health literacy is really crucial to everything we do in early childhood. And when we think that school readiness begins with health, health literacy is an extreme important element of health. And if we want to build a culture of health in early childhood, it needs to be done in an intentional way. So today, you're going to hear definitions of health literacy, its impact, and here's some examples of concrete application of how we can use health literacy not only to increase knowledge and create activation in staff and parents, but also to create engagement. And I'm really happy to have a wonderful presenter, and I've asked to present him instead of me reading a paper. I've asked Dr. Fante, who is here. She's the Associate Executive Director of the American Academy of Pediatrics, and she's the Director of the Department of Children's Health and Wellness, and I've asked her to present Dr. Dreyer.
Thank you, Ariella. Good morning, everyone. So when I was asked yesterday if I would like to introduce Dr. Dreyer, I jumped at this chance. And I only have 25 pages of information for you. Bernard, I started thinking how I could summarize all the wonderful work that not only you've done, but you've continued to do. I just have a few points so that you will get to know him as a little bit as we do. Bernard is the current president of the American Academy of Pediatrics, and we are so happy that he is. And the American Academy of Pediatrics has about 66,000 members, and it includes primary care and subspecialty care, and so we have had and we continue to have some of the best leaders who have all their careers served children and families. If you look at his CV, it's extensive. So Dr. Dreyer is in this context, a remarkable researcher. He's thoughtful and skilled in that category. Numerous publications, numerous national committees, also president of the Academic Pediatric Association in the past, so you can see that. He's a mentor to so many pediatricians, but not just pediatricians, to so many young people who are starting to be interested in the things that are so important to all of us. So this year, I will just say, Dr. Dreyer spent his career actually serving children and families, particularly who live in poverty, including clinics for children who are homeless, etc. This year, as president of the Academy, just so you know, when we have a president, they kind of decide what they want to be their issue for the year, and then they continue that, and you might guess that Dr. Dreyer's issue has been on children living in poverty. Through his leadership, we have developed and published the National Policy and Clinical Report on Poverty, which is not just used for pediatricians, but is used nationally in many settings, and this one too internationally. In addition to that, it's one thing to publish a policy statement and hope that people will use it, but we now have a strategic plan over the next 3 years at the Academy, really looking at what we can do with you all to make a difference in the lives of children and families who are living in poverty. It is a privilege for me to introduce Dr. Dreyer. He is a remarkable advocate for children and families and pediatricians. Please help me welcome Dr. Dreyer.
Thank you, Fan, for that beautiful introduction. I'm not sure who you're talking about. It's a pleasure to be here. This is Ariella and I share a passion for the issue of health literacy, which very few other people seem to share, to our chagrin. So I'm glad to see so many people are here. I was on the IOM roundtable on health literacy for quite a while, and there were very many like-minded people trying to get this issue before you. So I'm looking forward to talking today about this, and I'm rather than talk anymore, as long as I can make sure that this works. You're right. I have nothing to disclose. I always share that I wish I had something to disclose, but unfortunately nobody's trying to bribe me with anything. So just briefly, I'm going to give a definition and scope of health literacy, its implications for health outcomes. Then I'm going to focus on some of the work we're doing at NYU and Bellevue, and actually across the nation, because some of this is multi-center work, interventions to really help parents understand health better in the areas of medication errors, obesity prevention, and asthma, and then end with some final thoughts about what we can all do to make this better for families. This is a topic which could go on for hours and hours. There's a lot I'm not going to be talking about. So I'm going to start and go pretty fast through the topics and hope we have some time for discussion. So what is health literacy? Definition is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. That's a definition, that's the official definition. We usually add, and including access and navigate the healthcare system, because that is its own issue for many families. So you see, it's not just reading or literacy. It's really using information, making decisions, and so it's a complex structure. Most of how we measure health literacy in families is by giving them some kind of test, which is basically either literacy or numeracy. It's not really a measure of true health literacy, but it's all that we have. So I like to use this to think about health literacy. Health literacy is based on the skills and ability of in our case, mostly it's the parents, but it could be the patient, the adolescent for older kids, and the demands and complexity of the healthcare system. And frequently they're mismatched. And Ariella later is going to really talk about some interventions to increase the skills and ability of parents, which is a very exciting thing, and I'm going to make sure that we have enough time to hear about that. I'm going to mostly focus on thinking about what we can do to decrease the demands and complexity that we put on families when they interact with the healthcare system. And actually, it's not just the healthcare system. It could be the early childhood system. It's any system, really. Because the early childhood system deals with health as much as the healthcare system does. Okay. Before I go on, I just want to say that health literacy, and this diagram it impacts all of us. in the right situation, any of us can have health literacy issues. I usually just tell the story, and I'll tell it briefly. I was taking my wife to a surgeon to get some vascular surgery, and because I'm pretty important in my medical center, the surgeon spent about 20 minutes drawing diagrams and telling me all about the procedure that he was going to do. And I walk out of the room, and my wife too, and we walk out of the room. And as I walked out of the room, I realized I didn't understand a word that he said. I had no idea. And actually, if it had been about me, I would have just left, which is what most of our patients do. But since I knew my wife was going to ask me what he said, I got up the nerve and I walked back in the room and I said, I didn't really understand anything you said. You have to start over and do it differently. So the point of saying that is, yes, certainly low education people have more problems. Poor people have more problems. But we all have problems if the information overload is there. Health literacy of parents in the U.S. So there are, in 2003, the National Assessment of Adult Literacy actually included a section on health literacy. And we analyzed that to look just at parents in the adult group. And you can see that the basic and below basic categories are the people who really have difficulty understanding and dealing with health information. And that's about 29% of parents are in that category. What does it mean to have below basic or basic health literacy? Again, I'm not going to dwell on this, but somebody with below basic health literacy can't read a pamphlet and give 2 reasons why screening is important, can't properly understand a 1-page handout on hypertension, etc. Parents with basic health literacy can't use a drug label, can't interpret a growth chart, etc. So these are basic things. And so 29%, or almost a third of parents, are in this category. Next, implications for health outcomes. So this is a long list of poor outcomes associated with low health literacy. This is mostly from the adult literature, where most of the research has been done. And I'm not going to therefore read all the things here, but you can see behaviors, knowledge, health outcomes are all impacted by low health literacy. It estimates that it costs the U.S. about between 106 to 238 billion dollars per year because of problems with patients and families and people understanding what they should be doing to improve their health. But there are a number of studies in pediatrics, and these are some of the examples of some of the outcomes that we know are impacted. Decreased knowledge about asthma or birth control or immunizations, worse health behaviors with more smoking and less breastfeeding based on health literacy issues, increased use of health services, more ED visits, more hospitalizations among asthmatics, and poorer health outcomes with increased asthma severity, missed school, poor diabetic control among children. So it has a very distinct impact on health outcomes. I just want to throw this slide up. So the readability levels you can see here are mostly approximately 10th grade for most of the information we give parents. And the reality is that the recommendation is that it should be on the average 6th to 8th grade and 3rd to 5th grade for low literacy families. There are some health disparity issues here. So this is from the same 2003 NAL survey. You can see, if you can see from way back there, that certain populations, the purple and the white, are below basic and basic. And you can see that certainly African American, Latino, Native American, American Indians have, very significantly greater low health literacy issues. And then Medicare, Medicaid, and no insurance populations also have significantly greater health literacy issues. But I want to point out one other thing on this slide. At the opposite end of each of those bars are proficient. in the little hatched areas. And I just want to point out that almost nobody is proficient. So just keep that in mind, that there is a universal component to this that's very significant, even though, of course, we focus more on people who have much more problem at the other end. Parent health literacy and child health medication errors. So we'll first focus on some discussion of medication errors. So why outpatient medication errors? They're very frequent. About 50% of caregivers give an incorrect dose of liquid medicine, and 50% of pediatric caregivers do not adhere to the prescribed medication regimen. This is especially true in early childhood, and so it's very especially focused on, what we're talking about today. Medication administration errors account for about 70% of preventable pediatric outpatient adverse events. Liquid medications are difficult to administer, and again, this is early childhood. There's a variation in the accuracy of dosing instruments. There are different concentration. There are different units of measurement. All of this is very confusing. If you've ever looked at a bottle, an over-the-counter bottle of cough mixture, or which people shouldn't be giving to their kids to begin with, but if you look at what you're supposed to do with that information, it's very, very confusing. So strategies to decrease these include the use of plain language. For those of you, plain language is basically simple words preferred by parents and patients. And it's been shown that they're using plain living room language rather than a lot of jargon and long words improves understanding. We as healthcare professionals, and I suspect even early childhood professionals, tend to use the words we're used to using when we're talking to people rather than the words that they understand. So focusing on plain language, focusing on the use of illustrations and pictograms when you're giving written information has been shown to improve knowledge, adherence, assist with self-management schedules. The other things that we talk about are using concepts like teach back and show back. So teach back is asking the patient to say instructions in their own words or physically demonstrate the steps of an activity, and is associated with improved understanding and improved outcomes. And of course, in the case of liquid medications, providing a dosing instrument. So I'm going to talk a little about the intervention we've been studying at NYU in Bellevue. It's called the HELPICS intervention. It's patient medication-specific pictogram-based instruction sheets, and it's used as part of provider counseling. So one thing I would say about any written handout is if you hand somebody something written, it doesn't do very much for them. Written handouts are really only useful when you, as a caregiver, provider of any kind, focus the person you're giving it to on the important aspects of it. So these are plain language pictograph instruction sheets. We also include, as far as what this counseling is, that the provider needs to demonstrate what they want them to do, to use teachback, to provide them with a standardized dosing tool. And it doesn't take very long. I think people are always concerned that thinking about health literacy somehow extends your conversation with a family. It actually doesn't, and in the long run, it saves a lot of lives, a lot of time and improved outcomes. So this is an example of what the HELPICS medication instruction sheet looks like. It's patient-specific, meaning there's somebody's name on it, and the medication, as you can see in this case, is there, and the dosage. We make ours in English and Spanish because we deal with a very large Latino population. 80% of our patients are Latino, and about half those patients only speak Spanish, and the other half speak English but may prefer Spanish some of the time. It involves plain language, which means short words, no jargon, and it uses pictograms to represent preparation, such as shaking, route and frequency, as you can see, storage, duration, and then what to do if you have questions. We also give families a tracking reminder sheet, which they put on their refrigerator. And you can see this has a dosing diagram, which actually shows them the dose in the measuring instrument that they should be aiming for. It gives them a date and number of doses, and then it gives them a log where the doctor writes, sort of discusses a convenient time when the parent is going to be giving, for example, this medication morning and evening. So they know it's 9 a.m. and it's 8 p.m. and circles the start and end time, so the parent knows when they check off that last place that they're done with the medicine. We also have similar sheets for capsules and for PRN medication such as Tylenol as well. So our evaluation, we did an evaluation which we published, and we looked at our outcomes of interest. We basically studied a daily dose short course medication. In this case, it was amoxicillin or some other antibiotic for less than 14 days, and a PRN medication for fever and cold. And I'm just going to quickly go over the results. You can see here that error in dosing was defined as measuring more than plus or minus 20% of the prescribed dose. And you can see that in red, the control group, 40% of those families made an error in measuring the dose, whereas in the HELPIX intervention group, only 15% did. And this was for the PRN medication. For the daily medication, it was even more striking. Almost half made a medication error in the control group, and only 5% in the intervention group. So there was a dramatic decrease in medication errors. Briefly, adherence also improved. So adherence defined as not giving within 20% of the total expected doses. Again, almost 40% in the control group didn't do that, and down to about 9% in the intervention group. The point of this is that you can actually help change outcomes as far as medication errors, but just talking to them usually doesn't work. We actually have a web-based application that we've now instituted, and we're implementing this in several hospitals so that the doctor just fills in. You can see there are over 50 common liquid and pill medications, 300 variations of those medications, and daily dose PRN in English and Spanish. And we now have it in 2 different hospitals, so that doctors can actually fill this in, and then it gets printed out. We've now connected it to the drug ordering in both those hospitals. So this is now part of ordering a drug. In addition to printing a prescription out, they can also print these sheets out. And we've tested implementing it. So what we did is we instituted in one hospital, and then before instituting in the other hospital, we measured outcomes in both hospitals to see what the comparison would be, and now we have implemented in the second hospital. And so one question people ask is, will doctors use this? And the answer is about 60% of the doctors, or 60% of the time, doctors writing prescriptions for those 50 medications did print out a HELPIX sheet. And just briefly looking at I'll just move rapid. I don't know why this is. Okay. Go to this one. So dosing errors. So in the HELPIX hospital, you can see that before the intervention, there were about 37% dosing errors. We tested the families, and that's how we understood this. But after the intervention, that went down to about 16%. And again, in the control hospital, no surprise, there was not a significant change. There was no intervention. We wouldn't expect there to be a significant change. If you look at the HELPIX hospital and you look at those that actually got the HELPIX sheet versus those that didn't, you can see that there was an impact even if they didn't get it at that visit, because the doctor was now being trained to do all these other things and was doing some of those things as part of the counseling. But of course, if they got the HELPIC sheet, it was very significantly decreased. And so the number needed to treat, for every 4 patients who got a HELPIC sheet, we prevented 1 medication error. Childhood obesity prevention. So I'm going to briefly, again, go through this briefly. This is a cluster randomized controlled study at 4 different sites. It was Miami, North Carolina, Atlanta, and New York. And this started at birth. It was in pediatric resident continuity clinics, and the goal was to reduce obesity by age 24 months and improve pediatric residents' communication skills. And we created, again, low literacy strategies for childhood obesity prevention. We had materials were tailored to each well-child visit. There was 1 core booklet and for each well-child check, and then supplemental booklets on different concepts that providers could choose from. And then tangible tools at 2, 9, 12, and 15 months. There was in English and Spanish, and now Chinese. So the concept here was the green light concept, that there were things that were green that are good for your baby and you should give to your baby. There are things in yellow that are not so good and you should try not to give. And there are things in red which are bad and you should not give. And so that was the concept throughout these materials. At the end of each book, there was core parent-directed goals, doable baby step. We would ask the parents, okay, what do you think you can do that will help your baby's nutrition in the next couple of weeks? And try to get them to have a specific goal and think about doing motivational interviewing to see if they really could accomplish it. This is what some of the pages look like. We focused a lot. This is the, I think the 9-month-old page from the 9-month-old booklet. You can see portion size was one of the things we looked at, and we sort of tried to give them some idea about what an appropriate portion would be, and some in this case, giving them ideas about finger foods for their child. The actual foods we used were culturally tested by doing focus groups with our families, so that we chose foods that they did use, rather than things that would not seem appropriate to them. We also had sample menus to give them a sense of what would you give your child over the full day. This is the 15 to 18-month-old. We use the standard dinner plate with 2 vegetables, 1 in this case beans and rice, because for our Mexican families, and then 1 protein. And again, some examples for breakfast and lunch. We also had these other issues like breastfeeding, active time, healthy eating for the adults and children over 3, so focusing the whole family on that, TV, etc. We gave the following tangible tools: a 2-month onesie, which said, "I'm sweet enough," without, don't give me juice. In Spanish on the back, or in English and Spanish. 9 months sippy cup. 12 months we gave them those 3-inch measuring cups that could be used to see what a portion size would be. And then by 15 months they got a placemat that described portion size and what kind of portions you should give. So just briefly, I'm going to skip enrollment, but so far our data revealed that parent diet activity. So I just want to back up a little. The concept here is that these are very clear statements. There's very little words. You didn't see pages with thousands of words on them. They were actually mostly pictures, simple instructions. and easily understandable. And by the way, we've tested this out on higher education folks, and they love them too. So I think that's one of the important things about this. Pretty much everybody likes materials like this. Anyway, less juice consumption, less pressuring child to finish food, less TV exposure. The providers did very well. The parents reported that their providers, who are residents, that they were likely to receive the written handouts in the 90% versus 68%. A plan to make a change in diet activity was discussed 50% of the time. These are just some Spanish handouts, just to give you a sense of what the Spanish ones look like. And likewise, the Spanish plate setting. You can see some of the foods are slightly different in this version. And then this is the Chinese version. We instituted this in a community health center in Chinatown, and worked with. And this required much more change, I think, from the point of view of the words and the pictures and the foods than the Spanish version. As you might expect, you can see there's different foods on this plate, and this is some of the. So I think number one, in summary. If we want to do something about nutrition, I think parents need to be engaged. They need to understand. We need to have a conversation with them. And materials like this can really help us engage families and empower them to really make the changes that they need to do. And can do that pretty successfully. And there's also, and you're going to hear this over and over again, there's a cultural phenomenon. Culture is baked into health literacy, and understanding the cultural implications is key if you're going to be communicating about anything, certainly about health, but certainly about parenting. Understanding what health beliefs are, and when I finish, I'm going to end with a short story about that sort of describes how powerful cultural health beliefs are, and if you don't get at them, you're not going to really be helping families. Lastly, I'm going to just focus on the asthma action plan. So I don't know how many of you know about asthma action plans, but we're all supposed to give every asthmatic an asthma action, a family an asthma action plan. It's usually, again, related to red, yellow, and green. Most of them we find our families don't use ever and don't understand. And so we have worked on developing a similar pictogram-based, simple, low health literacy asthma action plan that families might use. And so that's what I'm going to briefly talk about now. So this is the HealthPic's written asthma action plan. You can see mostly white space, pictures, not that many words. The features are that it's patient and regimen specific. It's written in plain language. Uses pictograms and photographs. In our case, we put the photographs of the actual medications we prescribe to families. There are 4 key issues that we focused on. Medication instructions, of course. Spacer use. Many of our families do not use the spacer, which really improves inhalation of the medication. Importance of continuing daily medication when the kid gets sick. We find that many families stop the daily medications when the kid is sick, which of course is counterproductive because now he's sick, so he's supposed to get the sick medications. And also, culturally, many families do not understand giving chronic medications because chronic disease and chronic medications is it's not necessarily a health belief or concept in many other cultures. And of course, recognizing symptoms when the child is sick. So again, we have a computer-based version. The doctor can just fill in and have all these drop-down menus to pick the medications and the doses. It's currently available in English and Spanish. It has the child's name and date and the parent's email address because we email a copy of this to the parents, which is really an exciting new option. we're in the process of connecting this to the EMR so that, again, this can be pre-populated and printed out and emailed when you prescribe the medication. So this is what one looks like, and one of the things that's usable by providers as part of a clinical encounter. So it's printed and is online. You can actually look at it on the screen and point things out to the family. You can see that in the green version, we always include day and night. Usually things are given twice. In the yellow version, we have a copy of the green ongoing medication, so the parent understands they're supposed to continue doing that. And we've now included a button, a picture of the child inhaling, which if the parent presses on it on their smartphone or on their computer, will play a video which shows them actually how the child should be inhaling the video. So it's another concept in health literacy. How can we use video? How can we use cartoons to help families, to help everybody understand what they need to do? This is a busy slide. All I'll say is that so far, when this has been published, much better explanation of Flovent use, that's the inhaled steroid, reinforcement of the importance of the spacer, need for daily preventive medicine even when sick. And you can see all of these are, 96.7% versus 50%, 83% versus 43%, 93% versus 34% in the control group, etc. The pediatric providers prefer it, and it takes the same amount of time to use this version as the standard versions, which we've never found very useful. So the point of these is not just to talk about these, but to sort of give an idea of what kinds of things we can do as providers to really be able to communicate information to families, and how we can use other modalities other than pages of words to help them. I want to finish. Doing pretty well, right? Yes, I'm doing fine. I want to finish by talking a little about what we can do in general to work with families. I think the first thing is to create a shame-free environment. And what does that mean? I think, first of all, look around your center, see what the signs look like, see what you have posted on and information for families. All of that should be something that's easily understandable. We've really tried to, it's actually the message you give families when you have complex information all around your site, whether that's a childcare site or a healthcare site, is that you're expected to understand this. And what that means is when they don't understand it, they're much less likely to sort of ask questions. In addition, I think all the staff needs to be thinking about how to communicate orally in short sentences and clear sentences without jargon. Look at the forms you give people to fill out. Make sure that they are, if they need help, that there's a way that they can ask for help. So that's sort of basic. I think the next two things I'm going to briefly talk about are improving verbal communication and improving and using and creating patient-friendly written materials. So regarding improving verbal communications, again, plain living room language. There are some studies that looking at physicians that within 18 seconds, they revert to using at least one jargon word. We can't help ourselves. I teach medical students about this, and I'm constantly letting them go on and then saying, okay, this is the following jargon you used in the last, 3 minutes. So we all tend to do this because it is not jargon to us. And I know there's jargon in early childhood education. that we all use in talking to each other, and therefore it seems like it's understandable, but it's not. Slow down in talking to families. Don't feel pressured to give them all the information. Break it down if you're giving them more than one concept. Don't actually think you can actually get parents to understand more than 2 or 3 concepts at a session. Will remember none of it. And of course, check for understanding using teach back or show back. A few words about teach back. It's the most underutilized advanced counseling that is the most effective advanced counseling. And why is it underutilized? I think 2 reasons. First of all, people feel uncomfortable. They feel like they're testing a family or saying, okay, what did you understand about what I just told you? So that's exactly what you don't do. What I usually say is I put it on myself or on a family member. I want to make sure I was clear. I'm not sure I was clear in telling you what you needed to do when you bring Maria home. Could you tell me what you heard me say so I can make sure I was clear about it? So that, again, the message is not that you're thinking that they don't understand, but you're thinking that you're not good at explaining. Or, I know that your mother takes care of Maria a lot of the time. What are you going to tell her as the most important things for her to do when you're not home? So as long as I always say it's like, asking teenagers about sex. Seems weird at first, but when you do it a lot, it's a very natural thing, and you get your powder going and you're okay about it. Same thing with teach back. And I can just tell you there are 1 million research papers showing that using this technique reveals how much people do not understand of what you told them. And therefore it gives you an opportunity to correct your inability to communicate correctly and really empower them to do the right thing. But we did a periodic survey of pediatricians, and this was not high on the list of what most pediatricians do. And I'm not picking on pediatricians. It's just that that's where we have our data. But all doctors, and as I said, teach back is something that people in early childhood centers do with families. They tell them to do things at home. You give them advice. Anytime you're giving advice, you need to do it in a way, you need to check their understanding. And you need to not give them too much advice. We're all feeling we want to tell parents about everything, but if we tell them to do 10 things, they'll do nothing. If we tell them to do 2 things or 3 things, they may do 1 or 2 of them. Just to say, at the American Academy of Pediatrics, we focused on this somewhat, and there are not too many pediatricians here, but you might even use this just to give parents advice about sickness. There's a book called Plain Language Pediatrics. I was co-editor of it with Marianne Abrams, and there's a lot of advice to help providers about how to communicate. A lot of the things I've been touching on are in much more detail here. But in addition, there are about handouts for patients, 2-sided handouts for patients on 22 common conditions. This is the one on bedwetting. And again, lots of white space, diagrams, focusing on what's important to tell first, and the things that they may not need are later on in the handout. So before I'm finished, but I want to tell you a little about cultural issues. Cultural beliefs, we all have cultural beliefs. So cultural beliefs are not for other people's cultures, they're for all our cultures. I come from the New York upper class culture, highly educated upper class culture. Actually, probably one segment of that culture, and I have my own health beliefs about things. There's the deaf culture. I'm on the other hand, some of my patients come from the Latino culture, especially Mexican culture, or from the Chinese American culture. So that's one thing. Everybody has a culture. It's not just the other ethnic groups that have a culture. We all are acculturated to our own health beliefs. The other thing is that every person is different in their culture. So just because somebody is Chinese doesn't mean they don't believe in Western medicine. But we can make some assumptions, number one, that we probably should ask about. And I think the most important thing is to ask the universal questions of families about what their health beliefs are, and not assume that they have a specific health belief. So there's something called the Kleinman questions. And so basically there are a couple of questions which I always ask families. I shouldn't say always. I try to always ask families. One is, what do you think causes this problem? You know, how does it work? How do you think this problem works? What's going on in the body or in the mind or whatever? What do you think makes it better? And what do you think makes it worse? And I can tell you, if you ask those questions all the time, you'll be amazed. Not amazed. You'll be amazed in that you hadn't thought about that. And so I'm going to end by telling you a story where I totally screwed up with a patient with ADHD. I was taking care, I'm a developmental behavior pediatrician, and actually we have a whole program looking at children with ADHD, and I was seeing a five or 6 year old Chinese American boy whose parents were first generation Chinese. They sold stuff on the street in Chinatown. Lovely, sweet family. A lovely, sweet boy. He was uncomplicated, meaning he didn't have learning problems. He didn't have real behavior problems, but he was definitely had difficulty focusing, hyperactive. And I had a great interpreter. I don't speak Chinese, but we have one of my social workers speaks every Chinese dialect and is very culturally connected, etc. And so she was working with me in this family. And I wanted to prescribe stimulant medication, and I prescribed stimulant medication. I explained what it would do, that it would, decrease his hyperactivity and allow him to focus. And they smiled and said, yes, yes, yes. And then I saw them a week later, and they hadn't started the medication. And I asked them why, and they said they couldn't get it, or I don't know what the excuse was. And we tried again, and I sent them home again, and I saw them in another week or two, and they came back and they hadn't started the medication. And so this may have gone on one more round, by the way. But eventually I said, I need to ask those questions, which I always teach medical students to do. And I said, so what do you think is going on? What do you think is causing his problem? And they said, well, we think he has too much energy in his brain. And I said, and what do you think the medication is doing? And they said, we think the medication will keep the energy in his brain, and therefore it'll hurt his brain. And I said, and that allowed, and first of all, I felt, I can't believe I didn't ask this question 3 weeks ago, but I got over that quickly. And I said, okay, well, let me explain that again. Actually, what the medication does is let the energy out of his brain. So that's how it works. And guess what? They started the medication the next day. And they kept him on the medication for a while, and he was doing quite well. I haven't seen him for a while, but the reason I tell this story is there are a lot of stories like that you don't know about. Even when you tell parents what to do at home, how to play with their kids, how to talk to their kids. There are many beliefs that people have about child development as well as about medical care. I know that many in the Chinese community are concerned about mechanical devices, and so every time I give an inhaler, I check with them about how they feel about machines. Do they think what do they think about this? Is this a problem? Is this going to hurt? So I can try to change that belief by presenting it in a different way. So I'm going to stop there and turn this over to Ariel, but I appreciate you all listening to this, and I hope this touched on a number of the important issues in health literacy.
So we are going to switch gears a little bit. I'm not a physician. I'm just a passionate person about early childhood education, and I want to share with you today how we implemented the strategy to improve health literacy for staff, parents, and children, what impact we've had over the years, and hopefully you understand why this has become my life passion and fight. So we all agree that healthy children needs healthy and engaged adults around them. But how do we really create the right environment to engage staff and families? This is what we've learned. Parents and staff actively need to participate, not just to show up and be passive. Parents and staff bring and offer open hearts and open mind. It's a safe place. Parents work with staff in identifying and removing the barriers that they can face. And there is really a bidirectional communication. As a result of this, parents and staff are going to become more engaged and change through this interaction. There are a lot of barriers to involvement and engagement. To involvement, it's more practical barriers, such as transportation, childcare, work obligation, weather. To engagement, it's more cultural and emotional barriers, such as fear, suspicion, feeling of being unwelcome, power imbalance, misunderstanding, beliefs about each one's role. But the truth is that when we actively engage families, everyone will benefit. The children will be healthier and more ready to school. Families will be more engaged in the program and then afterwards continuing in the public schools. Programs can achieve higher levels of qualities, and communities will be able to provide stronger support. So through the National Center for Early Childhood Health and Wellness, we have taken one of our priorities as improving family engagement using health literacy. Now, if you look at this chart, the first thing is that health literacy, and as you heard from Dr. Dreyer, touches all the areas of health, whether it's health and safety, mental health, oral health, nutrition, physical activity. It can start during pregnancies and for children 0 to 5 for sure. But what we've learned is that really for health literacy to be impactful, you need a certain number of elements. You need management systems so you can implement strategies that will really create this change. You need to be able to create staff and parents engagement, and you can do it whether it's in home visits, whether it's in child care center, early Head Start, or Head Start. So we strongly believe that health is a foundation for school readiness. Children who receive timely and appropriate health and nutrition support will experience fewer developmental delays, have a higher attendance that leads to school readiness, will receive appropriate support to engage in learning activities, and will learn skills to build healthier lifestyles and decrease chances of failure due to illness. The truth is that health literacy intervention is really crucial in childcare because the earlier you start, the stronger the impact will be for a lifetime. So if you take as a starting point the parents' socioeconomic status, their culture, and their level of health literacy, these elements combined will affect child health. Now, it's not going to stop there because child health will affect school readiness through earlier identification of health condition and symptom, will affect average daily attendance, will affect ability to learn. So increasing the health literacy of families will improve child health, but will also have a strong impact on school readiness. And if we can take it a step further, this is really a dual generation approach because these children will become adults and they will become parents, and their level of health literacy will affect the way they raise their children and the impact on their health. So it's really the early childhood environment is the perfect place to really start these interventions, and they can have a lifelong impact not only on the parents or adults, but also on the children who will then become adults and parents themselves. So one thing that we've learned over the years is that all parents, no matter where they come from, deeply care about their children. And they should also be the key advocates for the health and well-being of their children. If we provide families with the right kind of knowledge and tools so they can actively participate in the decision-making regarding health and wellness of their children, okay, they're going to have a huge impact. So what we learn over time is that health literacy is one of the doors, but an important door to parents' engagement. So a little bit of history. At UCLA, we have been training for the last 26 years through the Johnson & Johnson program, Head Start directors from across the country. We've trained more than 1,400 directors, and I teach in that program. And this is how I got to know the Head Start and Early Head Start community. In the year 2000, I did a survey of about 600 Head Start directors, asking them, what are the major barriers that your families faced relative to health? And the answers that I got were not at all what I expected. The answers that I got were, we have a low attendance to training or health education session, even if we offer them. And the other element was, we often give our families material that unfortunately end up in the trash because they don't understand them. So based on these results, we created the Healthcare Institute 16 years ago with the mission of strengthening the managerial capacity of agencies, whether it's childcare, early Head Start, or Head Start, so they can provide more effective health education and prevention program. So to be able to do this, we had two parts. First of all, provide agencies with strategic management tool that will allow effective implementation of health education. And by this, I mean make sure that you engage your staff in this, make sure that you're able to market these programs and make them valuable to the parents so they come, remove the barriers, so there is no reason for them not to come, engage the community in that. And the second element was definitely provide culturally sensitive materials at a low literacy level, which was 3rd or 4th grade. And the truth is that through this project, we've really learned from the ground up. We started small, and we really saw how agencies are creative and implement it. Our goal was not to change cultures, but give tools to families. Now, we started with families, but with time we discovered that these kind of tools were really important for staff, who, as you know, big percentage of them were once families, Head Start families, and they all deal with this kind of issues. So what we learn over time of what makes health promotion more effective is that you need really intentional planning. You need commitment of the leadership. So every training that we do team training, but we also always ask the director to participate, because without buy-in from the leadership, nothing happens. We really share with them tools to engage staff, parents, and community. We provide low literacy materials. We let them adapt to their local community, which I think made really a big difference because it allowed the sustainability and the national implementation. And we also use data continuously. And I know that you hear the word data a lot in early childhood. In this case, not only did they collect data and share it with them, but we shared with them their own results, which showed them really the impact. And this is very motivating in early childhood settings to be able to continue this kind of work. And we included the love that I will speak in a few minutes. But we learned that meaningful change really takes time and intentional partnership to be able to succeed. So this is the model that we built over time. So we really did not start from the theory. We started from the practice. We learned from what was happening on the ground by traveling and seeing and adding the elements. And this is how we created our model. And I'm not going to go over every step, but just the main step are that we bring teams to train the trainer. And in the teams, we need someone from the leadership. Then this team go back, they train their staff. The staff trains the families, but we don't leave it at that, because we learn that nobody changes behavior after a one-time training. So we do follow-ups either through home visits or through parents' meeting. And at the end, we end up with a graduation, and we collect data before they start the training and 6 months after the training to measure the impact we've had. So the component that glues all this together is the love, and you have to know that this was developed by a Head Start director, and I took it and use it right now, and it stands for listening, observing, valuing, and encouraging. If this trickles down in any early childhood organization, it really makes a whole difference. Listen to what people say, observe what they need, show them that you value them, and encourage them. If this is done from the leadership to the management and from the management to the staff and the teachers, then you create the same thing with the families if it trickles down the right way. So this is the logic model that we use. And what I want to point out to you is that it's not a one-time thing. It's a whole system in which, besides, we create a partnership with the early childhood education centers, whether it's early Head Start or childcare, where we bring them to trainings, but we talk to them and communicate with them constantly, and they could communicate with each other about barriers, about successes, and this allowed us to have really outcomes that were both short-term, in other words, increase in knowledge, but longer-term that were medical outcomes and increasing confidence, and definitely on the long term we found increase in classroom scores, okay? Class scores for children of families that were part of these models. So these are some of our key findings, and I just chose a few to highlight the results. Before the training, okay, and this is a sample of close to 10,000 families, we asked parents, do you have a health book? And 70% said no. For the 30% that said yes, most of them did not know the name of the book. If you don't know the name, you probably are not using it very often. When we ask families, where do you get information about your child's health? And look at the impressive numbers that more than 70% get information from the doctor or the emergency room. And this is not really the place to get information on your child's health. Then we ask them, when your child is sick, where do you first go for help? And you see the word first is underlined because what's your first instinct? Again, 75% answer, their first instinct is to go to the doctor or to the emergency room. Parents want to do the best for their children, but this is their first reaction. So let me share some of the pre-post results and how this training really changed the knowledge and the behavior. When we ask parents, what would you do if your child has a 99.5? You look at the pre-results, and more than 40% would go to the doctor or to the emergency room for a 99.5. Now, when we saw this, we thought, 99.5 is really not a temperature. And we asked families, do you have thermometers? We found that they don't, so we started giving thermometers, but not only giving, also having them take the temperature and use it and learn how to read it, because 100.2 and 102 is not the same thing, whether they call an emergency line or a nurse. So the idea was that sometimes you really need to think simple what the problem is. And by doing that, we really changed. They knew that 99.5 is not a temperature. And they knew also when they need to go to the emergency room. It doesn't mean that you can find all the information, but information that tells you when is it an emergency would be really an important kind of tools. Another result, pre-post, what would you do if your child had a cough? Okay, so you see all the trends that we found is that the family started to use the materials. The materials were really made theirs. And for this specific training, we used a book called What to Do When Your Child Gets Sick, which is a wonderful book that is low literacy level. But I just want to highlight that just giving the book, like Dr. Dreyer said, made no difference. We tried. It's how you give the book, how you explain it, and what you give with it. So this is what really made the difference. When your child is sick, where do you first go for help? Look at the changes. Okay, the use of the book went from 4% to 47%. And there has been a huge decrease in doctor and emergency room clinic. So obviously, there is a cost saving. But what we were really focused is more on the impact and the well-being, right, of the families not having to rush to the doctor or to the emergency room as a first source of help. We collected this data of visits, doctor visits for early childhood symptoms, right? And you can see that there has been a decrease. And the same for the 5 main common childhood illnesses. Look at the biggest decrease is for fever, because parents now, it doesn't mean that they don't need to go, but they know that if it's 99.5, they are not going to go to the emergency room. And yes, we did have pediatricians and physicians who told us, how do you know that you're not missing, an emergency room that is really necessary? So we did track, and the training highlights when to go and when not to go. So the message is not to go, but just look at the information first before you make a decision. Now, these are the results that really are meaningful in early childhood education. First of all, we found a drop of nearly 30% in the average school day missed. And the same, we found a reduction in workday missed. And you know what this means for parents and how important this is. So obviously, school day missed is directly related to school readiness, but workday missed for families is linked to their stability, their financial stability. So it is really, really important. So qualitative outcomes that we learn for staff and families. First of all, an increased awareness, right, of health warning signs, a faster response to signs of illnesses, having a reference book that they use, okay, better understanding of common childhood illnesses, but also for the grantees, building leadership capacity on how to implement a training program on health education and promotion where you have an attendance of close to 90%. This is what we reached nationally, which was really a big difference. And being able to give materials to the families really that were meaningful. It definitely also increased the communication and the engagement of staff and families. So some pictures that we got over the years. This was one of our first training in California. It was a training in 2 languages, English and Spanish, that you can see here in the same room. This is a training that happened in Minneapolis, and I went to see this training. And I can tell you that when I arrived in this Head Start grantee, I really felt that I was at the United Nations, because they took the material and translated them. They had English, Spanish, we had, but they also translated them in Hmong and Somalian, which were the languages of their families. And you see they had 4 screens and the materials in 4 languages, and they had an interpreter. And if you take a look, each family had an automatic translation of the messages. And this is why I have so much admiration for this community or how they can adapt. And if you take a look, every family got this empty plastic box that you have there, which is an idea that I adopted afterwards. And as they were teaching the families about the thermometer was put in the box. They were showing them the importance of measuring correctly by giving them measuring spoons. They would put the measuring spoons in the box. So they end up the training with the first aid kit that they really knew how to use, which often is not the case for any of us. Half of what's in an emergency or first aid kit, we don't know how to use or we don't use. And that was a wonderful idea, and this is what allowed me my continuous improvement. This is a training that happened in Seattle. 7 languages. English was probably the smallest table, and I knew none of these languages. They were mainly East African and East Asian. But what they did, because their population is so diverse, they were very creative. They brought in resident and physician from the neighboring community, and they put the families in tables. And at each table, they had a home visitor, translator, and a physician. The training was done in English, but after every 10 minutes, they would stop, and it allowed the time to the home visitor to translate and to the physician to answer questions. This grantee did their first training about 10 years ago. And every year they have more and more physicians coming. And I asked some of them, why are you so interested? And they said, because it allows us to learn who our population is. So the physicians are not doing the training, but they're there to answer questions. And one thing that really struck me at this training, most of the parents, when they came, they were very covered and showing barely anything from their face. As the training was going along, I could see them opening and started talking and talking about cultures and their belief. And it was extremely powerful. Now imagine how powerful it was when the physician was a second generation who could speak the language of these families. So this is such an important way of integrating the medical community, not for them to teach, but for them to raise the awareness of how to speak to their patient. This was actually a second-generation Vietnamese physician who was sitting at the Vietnamese table. So the creativity of the work that you do really is what inspires me. And everywhere I went across the country, it was implemented according to the cultures and the families. This is a training that was done with migrant and seasonal Head Start. They're more limited in the time they can do it, but it was very beneficial. And this is a training that I went to visit in a Native American. And they also, they didn't want to change the culture, but they wanted to give the families the right kind of information. But obviously, all the incentive and door prices were more oriented to what is meaningful to these families. So that was really successful. So what does this program teach parents? How to assess and care for their sick children, how to manage acute illness, how to prevent accidents and injuries. And you have a few quotes because I've received so many thank yous from parents, from children, from staff. The training was exceptional and should be mandatory for all parents to attend. Excellent training. I have more trust knowing what to do now, all thanks to you. So that's for the parents. But from the grantees, okay, the grantees said that it helped them create a culture of health, that it aligns with the Head Start performance standards. And I want to tell you that if you looked at the new proposal for the performance standard, it's the first time that health literacy was mentioned. So I think this is a big step forward and it's going to have an impact. And I'm waiting to really see the final one as much as all of you, and we'll see. It improves school readiness outcome. It increases the engagement, okay? Because we're able to see that parents that came to one training wanted to come to multiple training. And we also had the data that gave a sense of accomplishment not only to us, but to each individual grantees. This program supports our thinking as a Head Start program, which is that one of the most powerful things we can do is not only to make a difference in the lives of our children, but also to affect changes of our families as a whole. So these are some examples of impact and comments. Now, like Linda Smith said yesterday, it's really a mixture, right, of hard data and stories that make this program so powerful and impactful. Now, over the years, we've learned that we can use the same model on any health topic. So when a grantee or a child care is trained on the basic strategic implementation, they can use it to do training on oral health, on prenatal care, on home safety and injury prevention, on obesity prevention. And actually, with the new cycle of the National Center of Early Childhood Health and Wellness, what we are going to do for the first time, we are going to work with grantees over a 4-year time span in which every year they come back for an additional topic. So this methodology, nothing happens overnight, and you all know that. It requires the effort of thinking strategically and implementing it. And once this is done, and you see the impact, you really see the engagement, right, of the staff and of the families. So far in the last 16 years, we've trained over 120 families in all ACF regions. We've been in 50 states, multiple community types, 7 languages, 10 ethnicities, early Head Start. We did 3 school districts, and we're starting to work in the childcare world. And as everything, it didn't happen to us overnight, right? The growth was, as I said, from the bottom up. We first were lucky to have a grant from Johnson & Johnson for 10 years that allowed us really to do the research and show that the method works and publish. Then we got an innovation grant that allowed us our first expansion, and we were part of the first round of the National Center for Health that allowed us to implement and expand to using common childhood illnesses. And now we take it a step further, we're really going to continue working and increasing the culture of health. So 120,000 families is a lot, but you can see that I'm not ready to retire because there's so much more to do, and we have a lot of work. Now, if we want to summarize what our model looks like, so one component is the strategic implementation. The second component is using low literacy and culturally sensitive material. And the third one, that I don't know if it intersects or it should really be around everything, is this love that is so important. Now, very often we were asked, is this additional work to what we already cannot do because we're so overstretched? But the truth is that it aligns with the Head Start performance standards, and it will align with the new ones too, okay? It gives you data, concrete data on parents, family, and community engagement, and it's definitely aligned with HHS priority to improve health literacy. So it allows you to do so many more things, but do them in a structured and organizing way with results, which that's the direction we're all going, right? We need to use data to make better decisions. So if I had a conclusion or a wish, is that we really need a coordinated investment by education and health system to support health literacy, okay, improving health literacy and skills of individuals, okay, and it is really critical to connect families having young children because that's the perfect time and that's when they are the most open to learn more and feel empowered and engaged. So it's important. I really hope to see that the proposal of embedding health literacy did not change when the performance standards come out. And my strong belief is that parents are the key advocates for the health and well-being of their family. They must be engaged. And empowered families really can make a difference, can change communities, and will lead to a healthier nation. I would just like to read you, and in a conclusion, a part of a letter that I received from an early Head Start director. A parent who has the tools to make appropriate decisions about the health care of their child has been given self-esteem. When a person has self-esteem, they can move a mountain. Mountains have been moved in the lives of the families that I work with through health education with love. That is the answer. Thank you very much. So I believe we have time for questions, correct?
Thank you both so much. Hello? My name is Bergen Nelson. Okay, now it's on. Thank you. My name is Bergen Nelson. I'm a general pediatrician at UCLA and soon to be at Virginia Commonwealth University. I'm a big fan of both of you. Thank you very much for sharing these really exciting work that you do. And my question is how, coming from both a clinical setting and from an early childhood setting, how we can get these providers to sort of coordinate their efforts, talk to each other, make sure that our messages and approaches are aligned with each other so that we can achieve synergy, because we really are touching the same families and we have similar issues and challenges, but often we may be at cross purposes or not understanding what the other's doing. So what are your recommendations for that coordination and communication?
Anar.
Hello? Yes.
Yes, it's open.
So, great question. I think a meeting like this is a good start. I think what we recommend to our pediatricians is to connect with early childhood people in their local community. I mean, I think all politics is local, but all relationships are certainly local. So the question is how to get that to happen. I think, you know, in the AP, I think we do have a child care coordinator in each chapter, and I think that is sort of could be a marching order for that child care coordinator, who's a pediatrician, to try to connect with the at least starting at the leadership of early childhood programs and then working their way down. One of the things I've done is with some of our local early childhood programs, they often like pediatricians to come talk to parents about different issues, so that's a very natural entree to develop a relationship where you can begin to think about these problems together.
I have the perspective not of the provider, but I believe that first of all, bringing a pediatrician to these trainings give them an idea of, you know, how to speak to these families. We've also just finished a pilot in Missouri where we brought in residents in pediatric to be part of the training, and it allowed them really to see and work with these families. In other words, they were not just invited, but they were doing the home visits, they were part of the training. So ideally, if I had a dream, this should be included in every school of medicine, but I don't think we're there yet, but we have to thrive from both sides.
I think just from the medical education point of view, from the pediatric education point of view, there are many programs that have community well, every program has some community pediatric time, but there's a CPTI program run out of the AP, which is in many training programs now, and the residents are out in the community, and I think many of them do spend time. I know almost all of them spend time in early childhood programs. I know our residents do as well, and that's another way of connecting them to see sort of what it goes on in early childhood programs and how important that is to the child, to the family, and the connection to the pediatrician.
Good morning. Thank you for your presentation. I'm Talitha Darrington, and I do training and technical assistance and research in early intervention and preschool special ed. For several years, I've done projects that are working on connecting health, pediatrics, and family physicians and early intervention, helping them know about early intervention, and don't just tell every family, oh, he's a boy, he'll grow out of it, let's wait and see, to make those referrals. Dr. Dreyer was just talking about that, and Dr. Herman talked about how the physicians would come to the trainings to learn more about their population that they're serving. I was wondering if you, and you talked a lot about how this work helped the families and the children, and I'm wondering if there's any observations or data being collected on how it's helping the physicians to learn about the connection and the importance of coordinating with health and with education and early intervention.
Bernard.
Well, I think she's asking, your experience, is this still on? Yes. I guess this is on all the time. I better be careful about what I say. So I think if I'm understanding the question, it is from your experience involving physicians in teaching families, do you have any data, or at least anecdotal data, on the impact it has on those?
One thing that we have data on parents following up on visits with pediatricians, which has been created through the engagement and the knowledge. Parents go also more prepared with questions, which makes, I believe, the work of the pediatrician easier. We have not collected data from the pediatrician.
Okay, well, thank you. Just a suggestion for the future of how we can continue to improve medical education, which has come a long way. Thanks.
Thank you. I should say just about parents being empowered to ask questions. We have an intervention that we have not published on, so I don't have data. I just have seems like a good thing to do. We have a waiting room program where we have volunteers sitting down with families, and we have a sort of a structured way of saying, what are your issues today? What are questions you want to ask the pediatrician? Helping them write them down and then bring that into the room so that they're not motivated but empowered to actually go in there with their questions to be answered, rather than sort of get overwhelmed with the visit and then leave without their questions being answered. So I think there's work to be done. And as I always say, that probably is true in childcare too. When they come, they may have many questions about what's going on with their kid in Head Start or any other childcare, and again, not quite get to ask those questions if they're not helped to be empowered.
Any other questions or remarks or comments?
Yeah.
Really short. Okay. I'll just hold it. I'm interested to know, part of the kind of health literacy to me would also be understanding the insurance system and the financial burden of health. And I think particularly what's nice about your program is that reducing ER visits is a huge way to reduce the family's costs. My husband works in the ER. But I was wondering, do you know of any efforts to help families understand and navigate Medicaid and health insurance, and knowing things about prescription coverage and how to get pre-approvals and all those things done, so that the financial burden is less for them and the stress is less for them to even obtain care, to help reduce their stress as well?
It's a wonderful question, and our life has not been long enough yet, but we are aware of the need of improving navigation and this kind of information to reduce the stress. Absolutely.
So my comment would be, and agreed, and that's why in my, if you noticed, I added navigation of the healthcare system as part of health literacy. I think there is now some recognition through the...
Oh, jeez.
Okay. I'm alive. Nobody shot me. Just to point it out. There are health navigators in larger centers that not only help people with navigating physically as far as where to go, but also help them with filling out forms, understanding insurance and issues like that. Those are primarily, though, going to be focused on low-income families or older adults on Medicare. So people who are on private insurance probably have fewer resources to help them navigate those issues.
But you're right, this really needs to be a national effort.
Yeah, absolutely. I mean, if you've ever... I love Obamacare, but if you've ever been on the site, try to figure out which insurance to pick and what exactly your cost will be, it's not easy. That would be a good place for health literacy interventions right away.
Any other comments?
Okay.
Okay, one more.
A question about the reality of the time that this takes. I'm a clinical psychologist. I work with the Head Start program here in Montgomery County and work with a lot of physicians. And I know that their time, the way children are booked for appointments in clinics, you have a child every 15 minutes or so. And I talk with a lot of physicians, including my daughter, who's a pediatrician and feels passionate about this. And she works in a clinic, but she says, basically, from my second patient on, I feel bad because I'm behind and I'm bringing people in late. So to do this health literacy in the best possible way, how does that mesh with the realities of how physicians are paid for their services, how clinics work, and how much time physicians have to do this?
So, of course, that's a great question. I would say I'll give you two different answers. One is that one of the things we did in our research about the interventions that I just demonstrated is time them and compare them to doing your regular work. And it turns out that it doesn't take longer most of the time. So the first thing to remember is we need to train physicians, providers, to communicate differently, not to communicate longer. And actually, I would bet if we actually did a time motion study, that a lot of this would save time because parents would, in our case, parents would actually follow your instructions. They wouldn't come back for extra visits. So if you look at the broader picture of time management, I would suspect that this would actually be cost effective. It's just changing the culture to make people spend the time to communicate clearly and also recognize that they should communicate less. I bet that your daughter, as a pediatrician, I'm not picking on her, I'm just saying as the average pediatrician, wants to give a lot of advice to parents at every visit and is probably talking to them too much from the point of view of what they can understand and break home. And so one of the things I try to teach people to do is say, what are the 2 or 3 things at this visit you think are the most important? Focus on that. And the other aspect of this is that with healthcare reform may be the wrong word, with healthcare transformation, we are going to be looking at teams rather than just the doctor. So it isn't just the pediatrician that has to do this, it's the team. There's a medical assistant, there's a nurse. And so what we really have to do is change how the team communicates, how the team addresses these issues, and not just say, well, it's the pediatrician or the internist or the family physician or the emergency physician. It's really the whole team that has to change.
And I would say that from our side, we try to prepare these families to really go and know the question to ask, and especially not leave if they do not understand the answers. So I really think that it's a transformation in the system, but that you need to work on both sides. Yes. No more?
Last chance.
Thank you, everyone,
thank you.
for coming. Thank you.